Right, we're going to move on because I should say as little as possible so that we can hear from our speakers. I'm really delighted that Dr. Lade Smith is here. I don't know how many weeks you are into being president of the Royal College of Psychiatrists, but it's not many. It's 6 weeks, and we've had summer in that time. So we're absolutely delighted to have you here with us today, and over to you.
Yeah, thanks very much for inviting me. And sorry I haven't been here for the whole day, but I was very interested to hear what, about Couth actually. And particularly because from my point of view, because I'm a psychiatrist, I'm a consultant psychiatrist, and I work at the South London and Moors of the NHS Foundation Trust. It's inner city London. We cover a wide range of people, wide range of different types of problems. And the area we cover is really deprived. It's got really high rates of crime, really high rates of violence, really high rates of substance use, and so on. And so it means that we end up seeing people who have the worst kind of outcomes, actually, and are often the most marginalised. And what's interesting is that, but everybody gets filtered to us, and what we need is something more like the kind of things that Couth are doing, so that, everyone has mental health, and then some people have mental illness. And so that we can really concentrate on the mental illness side of things. What I'm going to do today, I have to say, the organisers made a big mistake. They said, talk about what you like. I said, okay. Well, I saw there was something about evidence, and what I'm going to do is literally just talk about why it's important to use evidence and how you can, because I'm very interested in mental health inequality, and how you can use evidence to literally just recognise where the problems are and then do something about it. So all I'm going to do is literally go through a few examples, explain why this is important, and give you some ideas. And I'm hoping that there are some people in the audience who can actually take this away and implement some ideas. Okay, so just to remind you, we do know what causes mental illness. We know that genetics are a little bit important. Not as important as other things like perinatal factors are really important. For example, if you're born small for dates or if you're low birth weight, then you do have a much higher risk of developing a chronic psychotic disorder when you're in your early to mid-20s. We know that lead is important. The amount of lead in the environment is important. There's some idea that inflammation is important. For sure, as an adult, bereavement, moving house, things like that. Actually, as a child, moving house is important too. And of course, trauma as a child, trauma as an adult, very, very, very large driver of mental health problems. And then substance use is important too. And for those of you who are interested, cannabis, we've lots of talk about cannabis at the moment. There's a very nice paper that came out in the BMJ at the weekend looking at cannabis and the impacts of cannabis on various health disorders. It's really good for intractable epilepsy, not so good if you've got a mental health problem. Okay. So, if you think about adverse childhood experiences, and it's pretty well known now that if you have 4 or more adverse childhood experiences, then you are going to have a quite significant health problem later in life, physical and mental health problem. And the kind of things that you're going to have, it's really likely that you'll have a mental disorder, a comorbid substance use disorder. You'll die earlier because you started smoking when you were 9. You'll die earlier from chronic obstructive airways disease. You'll die earlier from heart problems. You're much more likely to die earlier in a fight, even. There's something, so it means that we already can start to recognise who's got the problems. The kind of things that are adverse, well, the obvious ones, being maltreated, being beaten up, being sexually abused, being emotionally abused repeatedly. And of course, if you're beaten up every day or every other day, or you're sexually abused, you're also emotionally abused as well. Things like, having to look after a parent from a very early age, that can be traumatic. Household adversity, you might not be the person who gets beaten up, but watching your dad and mum fight each other and your dad beat your mum every other day is actually very traumatic. Okay, so there are all sorts of things that it can be associated with, and very importantly, it really does increase the likelihood of you having poorer outcomes in your life as you become an adult. You're more likely to be in prison, 11 times more likely to be imprisoned. You're much more likely to abuse drugs, you're much more likely to come into contact with the kind of services that I look after. I'm a forensic psychiatrist, by the way. And the thing about all the work around adverse childhood experiences is if you go into any secure mental health unit and you ask any of the workers there, from the most senior consultant to the most junior healthcare assistant, and they will all tell you that the people that they look after have had horrendous lives. They've had awful lives. They really have. And yeah, there might be a little bit of genetics going on, there might be some familial stuff happening too, but they've also had all these horrendous, awful traumas. And we know that if you have 4 or more, I'm happy to say that most people haven't had 4 or more adverse childhood experiences, but they're the people we need to target. And I've got patients in my unit now, and I can tell you now, I knew if I'd met them when they were 3 or 4 years of age, I could have told you that they were going to become a patient in a medium secure unit by the time they were 20. And, unfortunately, it was literally written in the sand for them when they were 4 or 5 years of age. Because so many of us know that, it tells me that there's something we should be doing. I'm sure now, for those of you who didn't know that, and I'm sure it's fewer people didn't know that than did know that adverse childhood experiences are associated with poorer mental health outcomes, quite severe mental health problems, and more likely to be in secure units and so on and so forth, you would say, well, actually, that means we can intervene. Of course, what it means is that when these children are young, we should be, as I put it, sounding them with support. Because the one thing that we know is that when children are little, most people go to school. And if you're not at school, people kind of recognise you're not at school. Why aren't you at school? What's going on? Most people are usually able to sit in the classroom and, learn their ABCs and their 1, 2, 3s and all the rest of it. If you're not doing that, what's going on? There are all these tells. It's really obvious when a child starts to drop off the escalator of life. So it tells me that here's some evidence, it's pretty good evidence, that actually the children, and if you go to schools, you ask the teachers, they will know who are the children who've got the issues. Yet there isn't that joined up thinking from all the different agencies. And that doesn't mean to say wait until social services have to be involved. It's about thinking about it at a much earlier stage. Again, that thing of if you can intervene earlier, then you actually offset problems that will happen much later on. And there's this. So I like to show this slide because I like to remind people that actually, you can see this slide just shows, it's about poverty. It's looking at household income by quintile. So the people, let me see if I can use a pointer here. There we go. Is that going to work? Yeah, there we go. So the people here at the top end are the richest people in our society. The first thing to notice is this. Obviously, this is the prevalence of any mental health problem. Just because you're rich, it doesn't mean you're not going to have a mental health problem, right? Being rich does not protect you against mental illness, but it helps. If you are poor, you are over twice as likely to have a mental health problem than if you are richer. Simple as that. And why is that important? Well, it's important in terms of health, because we know that if you are poorer, you will spend 1/3, if you live in a deprived area, you spend 1/3 of your life with poor health. That's any kind of poor health, physical and mental. If you're richer, you'll spend half as much time of your life in poor health. And that's important. So we're in London at the moment. Now, those of you who will know London will have heard of, in fact, most people have heard of South Kensington. It's where all the beautiful stucco-fronted houses are, and all the museums are there. You have to be really, really, really rich to live in South Ken. Go 1.5 miles up the road, and it's North Kensington. Now, if you are born in South Kensington, if you're a man born in South Kensington, your life expectancy at the moment is probably about 84. You go 1.5 miles up the road, and your life expectancy is 5 to 6 years shorter, up to 10 years shorter. Because North Kensington sounds nice, but it's actually really deprived. Simple as that. And you can look at every single measure of deprivation. You compare North Kensington to South Kensington. North Kensington, that's the Grenfell Tower area. Okay, that says it all. Anyway, this also shows, this graph, that the poorest people in our society are people from Black, African, Bangladeshi, Pakistani backgrounds. And these are the people who have the worst health outcomes as well, interestingly enough. It also says, disaggregate the data, please. When you look at it more carefully, if you are from a South Asian background but you are Indian, then actually you're doing all right because you'll have just about as much money as someone from a white British background. And you're much less likely, these are the people who are Indian, they live in much less likely to live in a very deprived area. People who are Bangladeshi, Pakistani, these are the people at this end who are much more likely to live in a deprived area. And the people at this end have much worse health outcomes. This is the map. You might be thinking, why is she showing us a map of, the maps that are exactly the same? This is a map on the right. It's a map of depression and anxiety prevalence across the country. Okay? And it's the darker blue areas are where the worst levels of deprivation are. And, this is, you can obviously see it's a kind of north-south divide. The map on the left is not the same. It's actually a map of deprivation levels across the country. And it's darker blue is where there's more deprivation. You can see there is essentially a north-south divide. Why is that important? It's important because depression and anxiety prevalence rates in the north of the country, in particular in the northwest, are twice as high in the poorer areas than they are in the richer areas. And you can see if you look at Kent, this is Thanet. I don't know if people are from Thanet, been to Thanet. If you're from Thanet, I'm sorry, it is still like it, it's Dickens bleak. I'm sorry, it is, and it's not changed. Dickens wrote about how bleak it was. If you walk up the road, or because you probably have to walk because you haven't been anywhere, if you go up the road to leafy Tunbridge Wells, then literally, if you could get there as soon as possible early in your life, because your risk of having any kind of mental health problem diminishes enormously. And similar thing with Cornwall, which is really quite deprived, even though lots of rich people live there, most people who are Cornish actually are really poor. And they're really poor, and that translates to much higher rates of depression and anxiety. Sorry about that. This is a map some of you might recognise of Northern Ireland. And again, the darker blue areas are the areas where there's more deprivation. Now, obviously, there are historical issues around Northern Ireland. This is a place that's been totally traumatised, the whole population has. But on top of that, there's also the deprivation levels. Darker blue areas are where there's more deprivation, so around, if you like, around the sea bit here, and this is Belfast, these little bits here. Lo and behold, that translates to far worse suicide rates in those areas. So you've got really much higher rates of suicide in Belfast and around these sea areas, if you like, as I call them. Okay. So, what does that tell us? Oh, actually, let me just remind you, this is London. So you'll know that in London, there's this kind of pie. London's like, I was thinking about it as 6 pie slices. So the southwest of London is really leafy and lovely and affluent. And it starts in the middle and it goes out here, takes in Wandsworth and Richmond. Richmond's where people like Mick Jagger live. And then you keep going, you get to the Surrey Hills, and it becomes an area of outstanding natural beauty. Not so East London, okay? And not so the kind of South London, the bits where the taxi drivers never used to take you to. And actually, it's changed a bit, but, And the thing is that so what you can do is you can map the levels of deprivation onto mental health need going forward. And that's what these researchers did, Kousopoulos and Goldie. And what they did is that they thought, okay, here are the levels of the areas of deprivation. Where's likely to be the mental health need later on? And lo and behold, no great surprise, East End, South London. The big surprise is the bit of Westminster, because Westminster's got lots of homeless people. So it's the pink and the red bits are the risky bits, if you like, and the green bits are the leafy areas, the lowest risk. We did a study. What we did was to look at the association between social class and mental health treatment, actually. And what we found is basically if you are from a lower social class, you can't access mental health treatment. When you do manage to access it, you have worse outcomes, and especially when it comes to psychological interventions. Essentially, the psychologists and the therapists don't really understand your issues. That's a problem. That is a big problem. What does it tell us? It tells us that all the evidence tells us that we need to be modelling our mental health services better. We need to model them according to deprivation levels, And actually, we ought to be looking at the ICBs, that's the Integrated Care Board, looking at their spending and their commissioning and saying to them, are you spending commissioning appropriately according to the need of the individuals in your area? Minority stress. So this is Elon Mayer coined this term. He coined this term in kind of 1995. And it's actually, he's talking about the kind of stress that arises from being discriminated against if you're gay. And he kind of operationalized that, actually. And he talks about there's internalized homophobia, there's a stigma, there's the actual experiences of being beaten up, being actively discriminated against, spat at in the street, and so on and so forth. And he said, my theory is that that's associated with illness later on somehow. It must have an impact on people. It's interesting, it's akin to a thing called racial trauma, which was coined by a guy called Robert Carter in the States, saying that, look, black people are regularly subjected to, this is individual discrimination, not structural discrimination. He's talking about individual discrimination, and that can have an impact. It's a kind of emotional trauma. The question is there any actual evidence that that discrimination, that emotional trauma, increases the risk of mental disorder? And of course, the answer is yes, there is. Actually, it's been found that discrimination on the grounds of sex, gender, discrimination on the grounds of sexuality, discrimination on the grounds of your race or ethnicity are associated with a significantly high rate of mental disorder. And that's common mental disorder like depression and anxiety, but also there's increasing evidence that it can increase the likelihood of developing severe mental illness too. So, my take on that is make sure that your therapists are trained to work with discriminatory experiences when they see patients, just as we train our therapists to work with any other form of trauma. We just don't do it. And why is it taking us so long to work this one out? It's obvious, isn't it? Okay, finally, nearly. So I just want to show you this because it's, again, and this is one that I very much am, just like every other service provider, I've been guilty of this one. So this is just a table of, a chart of, a graphic actually, I think is the best term, graphic of inpatient admissions by ethnicity. And so just to remind you that the latest census, and this is a little bit older than that, but latest census, about 17 to 18% of the population in the UK is from a minoritized ethnic community. About 8% are Asian, 4% Black African Caribbean, or Black British, about nearly 3% mixed heritage, and 2.1% are other. Okay, and so the majority of people are white British in the country, or white British in the country, with a few white other in the country as well. So this is looking at, you can't see this very well, but the top line is adult acute inpatient beds. And adult acute inpatient beds, lo and behold, the majority of people are white British. But if you look at this, 9% are from a black background. That means it's twice as many as you'd expect compared with the general population. Okay. Now, what's interesting is that, I'm not going to go through it all, but when you look at inpatient rates by ethnicity, then you see that as the level of acuity, the level of need, and the level of security increases, then people from minoritized backgrounds are overrepresented, particularly people from black backgrounds. So you'll see that in PICU, that's psychiatric intensive care, 17% of the population are black. That's 4 times as much as in the general population. When you look at secure services, so for example, if you look at medium security, 20%, 21 to 20% of the population are black, 5 times as much as in the general population. Let's go back to the healthcare assistant in the medium secure unit. If I say to that healthcare assistant, this guy, you've seen them, and just to say that when you go into medium security, lots of people in medium, about 75% of people in medium security are people who've just graduated from general adult services. And they're people who have relapsing remitting conditions. They've often been in hospital more than once. I mean, occasionally, unfortunately, you get people who, on their first episode of psychosis, end up butting into the criminal justice system and they come that route, but many people are actually, they've been in hospital before, okay? Every single time they relapse, I say to the healthcare assistant, so what's the main reason why this guy keeps relapsing? And they'll say, well, you know, he disengaged, didn't take up his treatment, but to be honest with you, the reason he keeps relapsing is because of the drugs he takes. And there's a massive comorbid substance use in this group. It's so big that more than 95% of patients in secure service have a comorbid substance use problem. So obviously, what we should be providing them with are really good substance use services. Look at this. So this, bearing in mind that good 20% of people in medium security are black, we provide less than 1% of substance use services to black people. So what that's telling us is that the evidence is telling us that we are missing something here. Now, the thing about substance use services in the UK is that they're not just in the UK, actually. Substance use services primarily are based on a kind of opioid substitution model. So, you know, you take heroin and you inject it, and you are encouraged to stop injecting because it's really dangerous to inject, and instead to take something like Subutex, which you take orally, or methadone. You know, you will have been in the pharmacy and someone will have come in, they'll get a little bottle of methadone and go off, because it's safer, okay? And the problem is that, 1 minute, that's great. The problem is that what we don't do very well is offer services that do dual diagnosis. Or, you know, if you've got a mental health problem, you'll be turned away from addiction services, literally. So we're not really looking after those people who've got a mental health problem and a comorbid substance use problem at all. And yet these are the people who repeatedly end up in the higher end of services. And substance use, just to let you know, really does mediate violence. So what's the answer to that? Obviously, develop substance use services that are geared towards dual diagnosis provision and the management of harmful use of substances. This is just to say that this is advancing mental health equality resource. This is just a way. This is essentially an equality delivery system that we've designed. Helps you to identify the mental health inequalities in your local area. Helps you to work with your local population to work out how best they will take up your service. It's not to say to them, what do you think would make you better? Actually, we know what helps people get well. In fact, we're the experts in this. We know what helps. The thing is that most of the time, people don't get it, or they literally don't get the service. Think about the psychologist who doesn't talk to the person in front of them who's gay or black about the discriminatory experiences that they've had. We're not delivering the services well enough. And this is something to help you think about that, because you literally use change ideas to work with the local population to develop the service. So, in summary, interrogating the evidence will help provide solutions to what are seemingly, those wicked problems. And that can be at a structural, regional, or individual level. The most important thing is when you see it, don't feel like you can do nothing. Don't ignore it, because that's the easiest thing to do. It will take time. It'll take collaboration. But if you use something like an equity delivery system, you can break it down, use your change ideas, and you'll get there. Thank you.